Hi guys, welcome back. I shall now be discussing regarding the treatment algorithm for COVID-19 virus, that is SARS-CoV-2. You know, this virus has created mayhem and has contributed to unsettling our lives, but we'll definitely be able to fight it. Now, what I want to highlight here is some baseline data with respect to the virus before we actually get into the categorization of how are we going to handle the mild versus the moderate versus the severe cases. Well, first of all, you are aware that this would be a single-stranded positive sense RNA virus, and this would be having one of the largest. Now, I'm not saying that it is having the largest genome, because per se, when you look at the order nidoviruses, they would be having the largest genome, but included in the order nidoviruses would be like the coronaviruses. So one of the largest genomes which has been causing so much a problem for us would be approximately 30 kilobases. Now, you would have seen a lot of your relatives telling you that on one particular day they got tested and the report was negative, and they got tested the next day and the report turned out to be positive, and they would be blaming the laboratories for it, or they would be rather blaming the doctors for it. But I want to highlight what is called as eclipse period. What I mean by the word eclipse period is that it is the time that is required for the virus to actually make intracellular virions, and then you know the cytopathic effect will occur and the virus will escape into other cells. So there's a possibility that if a person will get tested in the eclipse period, which is approximately 10 hours, then the test could be actually negative. It could be a rapid test, it could even be a PCR that could be turning negative on one particular day. But once the eclipse period is over, once the virus escapes into other cells and the virus load increases exponentially, that is when the test will turn positive. So this is a concept which I want you to be aware of and explain to your patients, because majority of the time you would be having lots of hassles explaining to patients why a report from a particular lab is negative and the same report or the same test done from a different lab is turning out to be positive. The blame is not on the laboratory. It was that the patient was in the eclipse period. Now, when it comes to the incubation period, well, not much has changed. It's the standard data that you know from PSM also, that would be approximately 4 to 5 days. But then comes the query for doctors, like if you are exposed to a patient who was, let me say, having symptoms of COVID-19, then what is the upper limit? What is the upper limit till what duration can you be expecting to develop symptoms? So we should, as doctors, be also aware of median incubation period. Well, I want to tell you that what I mean by the word median incubation period would be that in 97.5% of the cases, the symptoms will definitely, if they have to occur, if somebody has had a substantial exposure, then this particular patient will develop manifestations by approximately 11.5 days. And the RO number of this virus is approximately 2 to 2.5. That is also the same data that I mentioned when actually the pandemic started. Well, it has not changed much. And what I mean by RO number is that one case can infect how many other cases. The problem is, unless and until the RO number does not decrease to less than 1, there will definitely be exponential increase in the number of cases, as we are seeing a second wave in India at the moment. So I just wanted to dedicate the initial few minutes for some baseline information. And then virus is detectable up to what duration? Because you see, in the end, I shall be discussing the discharge guidelines. You are now aware of the fact that in mild and moderate cases, we do not do testing at the time of discharge. One, it's a waste of resources. Number two, the virus can be detectable once the person has clinically recovered. The virus can be detectable up to 3 weeks. In fact, I have personally seen cases where the virus might be even detectable. RT-PCR might be positive even up to 2 months. So the point is, there is no logic behind or rationale behind testing a patient in especially mild to moderate cases. Yeah, for severe cases, once the clinical resolution, if there's going to be a negative RT-PCR report, it will give me confidence that yes, the patient is on the road to recovery. But in routine cases, there is absolutely no logic for doing the testing once again at the time of discharge, as the virus is detectable up to 3 weeks. On this, the query of the patient and lots of you would be that, is the person infectious for that long? Well, the answer is no, because you are not able to culture the virus. Whatever is being shared, though RT-PCR is positive, you are not able to culture the virus after approximately 8 to 9 days. So the point is that the virus load tends to decline. And this is also important because you would have seen that if you are to use antiviral therapy in the patient, you have to use it in the first 10 days or even earlier in case the patient needs it. I'll obviously come to, when are you going to be using remdesivir per se for the patient? And there are a lot of conflicting reports whether remdesivir is useful or not. But what I have seen and what my colleagues have reported that it does work. So I'll not get into speculations at the moment, but I want to tell you that timing is very, very critical for management of these patients, because is if you are going to be using antivirals after 10 days, it will not have any response, because usually after 10 days we have is a hyper-inflammatory state developing in a person. At that particular point of time, mainly it is the role of steroids, it is mainly the role of biologicals that might be used. So we'll come to the drugs subsequently, but I want you to be very clear with the fact that usually by 8 to 9 days, the virus levels would gradually begin to reduce, or even if the virus is being shed, it will not be culturable. So that means the person is not infective. In fact, the problem with this disease is that the maximum infectivity is present on the day the person is developing the symptoms, or maybe one day before the symptoms will develop. So at that point of time, with whosoever the patient will come in contact with, considering the RO number of 2 to 2.5, the spread will definitely be increased. And well, another point debatable is that, well, aerosol, you see, respiratory droplets are going to definitely transfer the disease, but whether you are having aerosolization of the virus is again something very debatable. But I personally feel that yes, aerosolization of the virus is definitely playing a role towards the spread per se. Now let's look at the impact that it will cause in the lungs. So I'm going to show you 3 slides there, and if you look at the first slide of the lungs, you can definitely notice very, I would say, beautifully organized lung infrastructure. You can see the alveoli, and you can see that how thin the separations between the alveoli are. But if you look at the subsequent slide, which is a relatively high-powered view of the lung parenchyma, you definitely can notice some very characteristic, very striking manifestations that I want to bring to your notice. The first and the foremost that you can notice at the movement would be a thickened alveolar septa. And well, what is the importance of this would be that the diffusion of gas would definitely be hampered. You can definitely notice a lot of inflammatory, all these blue spots that you see is the inflammation component which is present. So what I want to highlight is that when this disease would be causing manifestations in a patient, the hypoxia component, though we read about happy hypoxia, I'll explain the term also, I want you to understand that the inflammation in the lungs of the patient coupled with thickened alveolar septa, along with this, another important thing that will happen will be that the hypoxia component will damage the endothelial cells. So you will also read in pathology, or you will see the pathologist using the word endothelitis. And well, the bad news is if there's endothelitis, then fluid can definitely leak from the blood vessels. And once the fluid will leak out of the blood vessels, then you would be having is a development of non-cardiogenic pulmonary edema. And most of the time, the PO2 FiO2 ratio of the patient will dramatically reduce to less than 300. If it is less than, I'll give you cutoffs also. If it is less than 150, then definitely it would imply that the patient is deteriorating, and intubation is definitely mandatory for the patient. So I'll talk about indications for intubation also. But the point of the movement from the slide is that the gas exchange would be definitely hampered. And now I highlight why are we having so much of difficulty in treating hypoxia. I mean, the query from most of the relatives of the patients is that is it a big deal to treat pneumonia? I mean, they say that, sir, pneumonia is something that we have been hearing. I mean, if somebody is having a little bit of science background, they would be hearing the word pneumonia. So they are saying, sir, is it such a big deal to manage a case of pneumonia that you guys are losing patients, especially when it comes to the severe category, especially when it comes to intubated patients, you are having a 40% mortality. I mean, you say that your medical field is so advanced, and 40% mortality is something which, just would shock anybody. So let's look at what is the problem that we are actually dealing with. You see, what this virus is causing is that there can be a complement activation. Now, when you study the basic, I would say the basic pathogenesis of the disease, you would realize that this virus is causing inhibition of factor H. Now, what is factor H? It controls the activity of the complement system. You very well know that from your pathology. So if there's going to be inhibition of factor H, there's going to be uncontrolled complement mediated activation, and this complement system will cause mayhem because it is damaging the blood vessels. So one, I want you to remember that there would be a complement mediated vasculitis in the lung parenchyma. And most importantly, I would like to highlight that there can also be release of tissue factor. Now, these two things that I mentioned, like release of tissue factor would be like adding fuel to the fire, because the combination of the two things, that is complement mediated damage and the release of tissue factor, which will activate the clotting system, is going to cause formation of microthrombi in the lungs. So what you're seeing in a chest x-ray is not only the infiltration component, not only the consolidation component, but all those whiteness that you are seeing, all those ground glass vast opacities that you're seeing in the peripheral zones, they are millions and trillions of microthrombi in the lungs. And you can very well understand, if there's going to be microthrombi developing in the lung circulation, it's going to cause an extensive ventilation perfusion mismatch. And that explains why the severity of hypoxia can dramatically increase. And obviously, with comorbidity coming in, the person can deteriorate very fast. I would like to reiterate the fact that two important things which are causing you as a doctor to have difficulty in management of these patients. You are definitely using antithrombotics, you are using unfractionated heparin, or let me say low molecular weight heparin, whatever is available in your hospital. Why? Because these patients are developing not one, not two, but multiple, I would say millions of microthrombi in the lung circulation, and they are causing a gross ventilation perfusion mismatch. So if it was a routine pneumonia, we would have been very comfortable handling it. But this is a combination pneumonia plus microthrombi in the lungs. Once the cytokine storm hits, usually by the 10th day onwards, that's when you usually see a deterioration. That is when things become difficult for us to manage, because though you're using heparin, you're trying to neutralize the clotting activity that is occurring. But then you very well know from your experience as a medical doctor that handling DIC is so difficult. Similarly, here I'm not saying this case is having a DIC. What I'm saying is a pathology partially identical to development of DIC, in a sense that the D-dimer S is going to be skyrocketing, the acute phase reactants are going to be skyrocketing, and the ventilation perfusion mismatch is going to be really difficult for you to manage. Coming to the clinical manifestations of this patient, I would like to artificially divide this into stage 1, 2, and 3. That would be early infection, then a pulmonary phase, and a hyperinflammatory syndrome. And as I highlighted, depending on what time the patient is coming to you, timing of the patient is very critical, because antivirals will mainly work in either stage 1 or stage 2, that is early infection of the pulmonary phase. Now, you're aware of the fact that the ACE2 receptors are not only present in the lungs, they're also present in the upper respiratory tract epithelium, they're present in the heart, in the kidneys, and even in the GI tract. So obviously there can be diarrhea, they can even be COVID-19 myocarditis, they could be MI and a cardiogenic shock that needs to be handled. So I don't want to complicate things by saying that multiple organs are involved, but I want to say that primary problem of the patient is obviously a pneumonia with microthrombi, but you have to be mentally prepared to handle multi-organ dysfunction that definitely can occur in these patients. Now, if you look at the representation that I am currently zooming in, you will notice the fact that the viral replication tends to reduce subsequently. And as I told you the figures, usually by the 8th to the 9th day, the virus will become non-culturable. When I say stage 1, it basically means early infection. And in the early infection phase, most of the patients would be having very limited symptoms. One of the very striking symptoms that what I found personally and would be, noticed by you and your relatives or patients whom you saw was anosmia. Along with this, they can definitely be fever, but there is no shortness of breath at this particular point of time. Patient might complain of throat pain, or there might be a mild cough present in a person, and yes, loose motions in the form of diarrhea, which will definitely respond to symptomatic therapy. So at the moment, everything is cool. But as the patient progresses to stage 2, that is when problems will start occurring, and that is the time when the pulmonary component of the disease develops. And now we should be ready for this person to actually, possibility of it, obviously I'm not saying everybody will deteriorate, but the possibility of a patient deteriorating into ARDS is definitely to be kept. This is the time when patient will start noticing shortness of breath. So two parameters are important: respiratory rate and SpO2 for your exam perspective, because that is how you will categorize the patients as mild, moderate, and severe. Please appreciate at the moment I'm talking about the phases of the disease. I'm not talking about the categorization as mild, moderate, and severe, which will occur subsequently. But from the shortness of breath component, I just want to highlight the two important parameters that would help you in categorizing your patients will be respiratory rate and SpO2. I can just give you two figures at the moment verbally, and I'll write them down subsequently. Remember the numbers 2494 and 3090. What I mean by 2494 is that if the respiratory rate is more than 24 and SpO2 is less than 94% at room air, definitely that's a moderate case. 2494, that's what I said, right? Second, I'm saying 3090. What I mean by 3090 is if respiratory rate is more than 30 and the SpO2 of the patient is less than 90 at room air, it means that that would be a severe case. So if you just get the numbers right, that will definitely make your life relatively more comfortable. And yes, you will see a lot of patients who are hypoxic, but they might still be walking in the ward. That is, happy hypoxia is a manifestation that you see with these patients. I just want to highlight that human body has great capabilities of adaptation. So yes, the X-ray is going to be bad. You might actually look at the X-ray and say that this guy is in ARDS, where the patient is sitting comfortably in the hospital bed, and in some cases he might be, ambulatory to the level that he can go to the washroom by himself. This is the usual presentation with respect to day 6 to 10, though obviously it can vary, but that's the standard data that you will see. And then usually by the 10th day, though the deterioration in some cases, especially with comorbidity, especially hypertension, diabetes mellitus, can occur earlier also, but in majority of cases you will notice that once the patient goes into stage 3, you are going to be having a hyperinflammatory response, and that is where the major role comes of steroids and not convalescent plasma. You see, what was happening was, and why I would say the convalescent plasma was being criticized, was because we were using it at the wrong time. We were using it too late. If you are going to be using convalescent plasma at this point of time, it will not give you an advantage because the virus replication has dropped dramatically. Remember, I told you the virus is not replicating after 8 to 9 days. So there's no point in trying to hit the virus with convalescent plasma, which will be having antibodies. At the hyperinflammatory phase, you need to use biologicals or you need to use steroids for the patient. So as I said, timing is very, very important. And this is the time when the patient can land up into ARDS. They can definitely be sepsis. They can be multi-organ dysfunction developing in a patient. Most importantly, they could even be cardiogenic shock due to COVID-19 myocarditis. The coagulation disorder that I'm talking about, that usually begins with respect to stage 2 and stage 3. And this is the time, therefore, you need to remember that in pulmonary phase, in a lot of cases, especially the moderate ones, where I gave you the figures of 24, 94, remember, respiratory rate more than 24, SpO2 less than 94 at room air, you are supposed to start heparin in the patient, because that is when the coagulation problems in the person will start developing. Now, most of the cases will recover. So I'm not worried about the mild cases. Absolutely not. I am more worried about the moderate and the severe cases. And from the exam perspective also, what they have asked and will ask you in the exam would be management of a moderate to a severe case. Now, before I show you another representation identical to this and talk about the testing part, at this particular junction, I want to specially highlight the fact that when it comes to, diagnosis of the disease, it is not that RT-PCR is the only and the most accurate test. Yeah, it is important, and the gold standard test is RT-PCR, but rapid antigen tests are good enough. You see, I explained the concept of, I would say, eclipse period to you. So the point is that RT-PCR can pick up the disease relatively earlier as compared to a rapid antigen test. But it's not that only RT-PCR will help you in confirming that, okay, this is SARS-CoV-2 infection. Even a rapid antigen test can be applied on a wider scale. So it's not that because it is a cheaper test. I mean, that's the thought process of a lot of patients also, that because it's a cheaper test, it will have less accuracy. No, that is not the case. It is just that the turnaround time is relatively lesser. So you can work out the case relatively faster. I highlight the fact that the virus might be shed even up to 3 weeks, but then that virus will not be able to infect other patients. Another aspect I want to highlight is, and though why I'm saying this at the moment is because in the treatment of the mild case, though in the government protocol hydroxychloroquine is given, I will not be rating hydroxychloroquine, because you very well know the fact that in the Solidarity trial, even in the NIH trial, hydroxychloroquine arm was removed because it did not show any benefit. Though the dosages of hydroxychloroquine that was used in Western studies was much more than the dosages that we are using, but why did the ICMR so stubbornly persist in giving hydroxychloroquine in mild cases right up to, I would say middle of 2020, hydroxychloroquine was being used even in mild cases. So why was ICMR so adamant? So I had a chat with one of the senior people, and what they told me was something very interesting, which the thought process of me as a doctor was, if this is not effective, why are you giving it? Their rationale was that hydroxychloroquine has been shown. They said, okay, it is not effective, fine, with respect to moderate to severe cases, but it has definitely been shown to reduce the replication rate of the virus. Remember, I said by 8 to 9 days, the virus load will automatically reduce. They said with hydroxychloroquine, it has been shown that the excretion of the virus will become relatively lesser for, let me say, 3 to 4 days. So if you give hydroxychloroquine to a case of COVID-19 who's a mild case, you are basically reducing, you're not treating that guy very effectively, but you are reducing the infectivity of that guy to other people in the community. So I reiterate the fact, and that was a very intelligent thought process, though ICMR was being criticized by everybody left and right, everybody was like, kya ICMR wale kya bol rahe hain? But you see, the thought process was a very intelligent process. They said, we are not trying to treat the case, is we are trying to reduce the infectivity of the person to other people, because anyway the disease was going into a community phase of transmission. So the thought process was at least one case should be infecting lesser number of people. So let's not criticize the authorities blindly just by saying ki bhai, just because Western data is saying it, they are having a rationale. So that is why even currently, agar aap protocol padhte ho, if you download it from MOHFW, in the mild cases, they are still mentioning hydroxychloroquine. I mentioned the reason or the rationale behind it. You are trying to reduce the infectivity to relatively other number of people. So now let us look at this representation where I'll be talking about especially a patient of severe COVID, and you can notice usually by the 10th day, that is when the hyperinflammatory response would be developing. I was talking about stage 1, that was early infection, then stage 2 where I highlighted this would be the pulmonary phase, and you can notice when I'm writing the pulmonary phase, the viral shedding is definitely becoming lesser. Most of the patients usually by day 10 can deteriorate, and that is where the complications like ARDS can develop in a patient. And then obviously, I mean, depending on the treatment algorithm that you deploy and presence and absence of comorbidity, recovery can occur or even death can occur in the patient. Coagulation disorder, you can see the timing. The coagulation disorder can start as early as by day 5, and therefore in moderate cases, you are using to handle the coagulation phase. I mean, the query of a lot of doctors is, in a moderate case, why are you using heparin? You should be using heparin only with respect to severe cases. No, I want to preempt the fact that if the coagulation disorder is starting as early as by the 5th day and it's a moderate case, I would be more comfortable giving heparin to the patient. So all of these data, especially the Indian data, is very simplified. When you look at the Western data, it's a lot of complication with a lot of flow charts being made. The Indian data is very simple, one-page information that they've given, and it is good that these experts are given a one-page simplified algorithm for management, because the more complicated you make it, lesser, I would say, the effectiveness of treatment will dramatically reduce, because anyway we do not have a short treatment. So why to make life difficult for any one of us by going into 3-hour, 4-hour discussions and having a complicated algorithm? They just kept it one page, straightforward, precise, to the point, and get the patient out of the mess. Coming to the workup of the patient, the best way for diagnosis would obviously be, as I said, RT-PCR, and you can be expected to take samples with respect to nasopharyngeal swab, and you obviously should be taking a oropharyngeal swab as well. With respect to a nasopharyngeal swab, the neck of the patient will be slightly extended to approximately 70 degrees, and then you are to introduce this swab, and most of these swabs would be having a marking. I mean, the marking would tell you till how much distance are you supposed to insert it from the nostril. But I have seen also that in some laboratories they are using these swabs which are not having a marking. So what should be the distance by which the swab should go inside, because you're going to take the sample from the nasopharynx, and again the sampling errors can definitely be there, which is another reason why the report might be negative from one lab and can be turning positive from a different lab. But I said more important than the sampling errors, because our technicians are also trained, is the eclipse period concept that I explained to you. So the testing could be negative on one day and turn positive subsequently. The distance from the nostril to the nasopharynx, I'm just using a short form here, NP here would mean nasopharynx, that the posterior wall of the nasopharynx is approximately 8 to 10 centimeter, and you are not supposed to use calcium alginate swabs or wooden shafts. I repeat once again, I'm just putting a crosshair to say that you can use a plastic cannulas definitely, but the shaft should be made of either plastic but should not be made of wood and should not be having calcium alginate. That's just a technical aspect that you should be aware of. And yes, then the RT-PCR report would be giving you a CT value, that is a critical or a cycle threshold value. Now the importance of knowing the CT value or the cycle threshold value is that this is inversely related to the virus load. I repeat the statement once again. If the CT value is lower, it means that the viral load is high, because the machine had to, the genetic material is amplified in PCR, so the amplification cycles were relatively lesser. I want to highlight this fact that if it is a low CT value, it means a high viral load in a patient. But then again, viral load per se will not decide the prognosis of a patient. It is whether hyperinflammatory syndrome is developing or not will decide the prognosis of a patient. You will notice a lot of patients who go into a moderate phase or moderate presentation, they are having shortness of breath, they might be having hypoxia, the lungs are really bad, but they come out of it. So the problem is that we do not have a independent marker. There are a lot of tests which are telling us that okay, the patient has gone into hyperinflammatory state, interleukin 6 would go up, CRP will skyrocket, and I'll talk about neutrophil lymphocyte ratio as well. But the point is, we do not have one single test by which we can predict I'm talking about prediction, not identification. Hyperinflammatory state we can identify, obviously. What I'm saying is we don't have a test by which we are able to accurately predict whether someone will go from a pulmonary phase to a hyperinflammatory state. And the day we are able to identify that marker, obviously our capability to handle this manifestation or the manifestations of the disease will dramatically improve. Now, I want to highlight that RT-PCR is definitely the gold standard, but then even if we are talking about a rapid antigen test, it will be having a good amount of sensitivity and they're good enough, and the advantage is the turnaround time will also be relatively lesser, so you will be able to identify more number of cases. So if they ask you what is the best test for diagnosis, our answer is not a chest x-ray, our answer is not a HRCT. Yes, they definitely show findings, but we are not going to use radiology for diagnosis for any infection per se. As you know from a microbiology classes, you need to demonstrate the genetic material of the infection, or you need to demonstrate the presence of the antigen. And yeah, antibodies, again, they do not have a role per se in diagnosis, because antibodies will take some time to develop, and if I want a early diagnosis, I'll be more happy with a PCR or an antigen test. Apart from this, additional tests which would be required for these patients would be in the following sense. Let's just have a look at the traditional way we are doing a workup of these patients. What are the routine tests that you're writing? So obviously cell counts will matter, and you will be getting a TLC of the patient done. You will always notice that since it's a viral infection, there will be a substantial lymphopenia in the patient, and lots have been talked about neutrophil lymphocyte ratio. Now, the older I would say publications, whether you look at JAMA or Lancet, they were saying a neutrophil lymphocyte ratio of 3.5 or more is substantially sufficient for identifying that the person will deteriorate. But in the later publications, you will notice that the neutrophil lymphocyte ratio was increased to 6. That is when they said that if the value is turning out to be more than 6, the patient is deteriorated. In the latest publications that I have seen, though this might be disputable, because you might say, sir, we have been taught 3.5. I agree to that, but that is the older data. Neutrophil lymphocyte ratio, the higher the value is, more is the problem for the patient. And in the recent publications, I saw that if the value is turning out to be more than 17, then the higher is the value, more are the chances of the person deteriorating. This is definitely indicating a poor prognosis. And as I was saying, our ability to predict whether somebody will or will not deteriorate will determine how aggressively we treat a patient. So that's why I highlighted that this is one of the crude markers that we're using at the moment. Then you will obviously notice that because of the hypercoagulation state, the anti-clotting system will also get into a overdrive. If they have a clotting system getting into overdrive, the anti-clotting system is obviously going to physiologically respond to it, which will explain the fact that D-dimer assay values will definitely start skyrocketing, and higher the D-dimer assays, you definitely know that you are in for trouble. Apart from this, I would like to mention some alarm markers. Alarm markers would be like CRP. It could be high sensitivity CRP, or you could do a conventional CRP. Then could be LDH values, which could be skyrocketing, ferritin, and cardiac issues will definitely develop in the patient. Interleukin 6 testing is something which may not be widely available. So yeah, if it's available, we can definitely evaluate it, and the values will anyway be elevated in a hyperinflammatory state. Now, the cardiac status of the patient is also very important, because lots of patients can have even a myocardial infarction. This could be occurring even post recovery from COVID. Then tropoil values will definitely matter. If the person goes into heart failure, I would like to definitely test the patient with pro-BNP, that is B-type natriuretic peptide, and I'll be deploying Framingham criteria for identification in case that is developing. Along with this, obviously a chest x-ray will be welcome, and there is a possibility that in early phase, obviously the x-ray will be normal, but the traditional finding that you will be getting in the x-ray would be middle and the lower lung zones. So you definitely can notice, I'll just zoom it for your convenience. You will notice that in the middle lobe, in the lower lobe, in the peripheries mainly, there is definitely multiple opacities present. So when it comes to a radiological interpretation, most of the time the x-rays will be having a pretty clear picture. So I don't think so that you would ever be able to mistake this for anything else, even if they give it without history. COVID-19 has been, I would say, an infection so common that I have seen non-medical people, just sending me a x-ray and saying, sir, I think I have got COVID. So, if a non-medico can identify the characteristic pattern, I'm talking about intelligent people who are saying, sir, that I'm seeing the whiteness only in the outside of the lungs. Does the disease not affect the inside of the lungs? They don't know what is medial, what is lateral, but considering the anatomy of the airways, the infection tends to disseminate into the periphery towards the pleural side. So you will be able to notice multiple opacities, as I highlighted. They would be present bilaterally. with predilection towards the periphery, towards the pleural side. And most of the time, it's obviously the whole lung can be involved, but most of the time what we have seen is the middle and the lower lobes getting involved. Then would be HRCT findings. Obviously the radiologist has done a very great job in describing each of the findings, but when it comes to HRCT, I just want to highlight that you will again be able to notice, and in the image that I have attached here, you can notice that again towards the periphery you are having ground glass opacities. Now prior to COVID-19, ground glass opacities is what we used to study with interstitial lung disease, but now we're having pneumonia which is contributing to these manifestations. It would obviously be an interstitial pneumonia developing in the patient, which is causing thickening of the interalveolar septa, and thereby the gas exchange is getting compromised. Other radiological findings that might be given are like crazy pavement pattern. Now, traditionally, prior to, I would say, March 2020, whenever we used to study about crazy pavement, the disease I used to always teach was PAP, that was pulmonary alveolar proteinosis, and that's a separate lecture in the app. You can go through that. So I used to talk about crazy pavement with respect to pulmonary alveolar proteinosis. Now we are talking about crazy pavement even in COVID-19. Another one is reverse halo sign. So these are signs which are highly suggestive, You might even get a lymphadenopathy sometimes. You might even have a mild, I would say, mild lymphadenopathy, but that's I would say that's not too much to be given importance for, because anyway, if there's an inflammation, there could be enlarged lymph nodes, but that could be enlarged due to some other coincidental infections which could be pre-existing in a patient, like tuberculosis might have occurred in the patient earlier. That could have resulted in the lymph nodes getting enlarged. So enlarged lymph nodes would not be a very, I would say, findings suggestive of COVID-19 infection, but these three findings that I've highlighted with respect to HRCT definitely give credibility to your diagnosis. And when it comes to, I would say, monitoring the patient, then you have to monitor the patient not on the basis of HRCT and X-ray chest. Like I see lots of times CT being repeated or X-ray being repeated. Well, there's no advantage of that. You can just monitor it with help of what I can casually say the word alarm markers. These are the ones, point number 2, point number 3, point number 4, 2, 3 and 4 that I've highlighted. I can call them as alarm markers. They are the ones which are to be repeated every 48 hours, in severe cases even earlier than that. So you need to basically identify whether your patient is improving or is deteriorating. Improvement will be, in your face. I mean, when you go to the bedside or when you are looking at the respiratory rate, SpO2 monitoring chart of the patient, you know that the recovery is occurring. But the deterioration can occur very, very fast. So your role as a doctor primarily is to identify the sudden deterioration or the potential for deterioration by looking at these alarm markers. So X-ray would not help you because, as I said, I have seen cases where the X-ray is really bad. It looks like a frank, I would say, the severe variety of ARDS. My thought process on looking the plain X-ray film was this guy would be having a SpO2, PO2, FiO2 ratio of, let me say, less than 100. The diagnostic criteria for ARDS is 300, but then we have categorization mild, moderate, severe. So the X-ray was so bad that I thought that the patient is having severe ARDS, and the patient was comfortably talking on the phone. So, I mean, X-rays can be highly deceptive, CTs can be highly deceptive in this condition. And that is why, I mean, per se, I would say repeating radiological investigations would not give you too much of advantage. And even the resolution of these findings I have seen might take more than 6 weeks. Lots of time the radiological findings are persisting for that long. So repeated, I would say, radiological investigations would not have any implication either in the changing the course of the treatment, neither it will have any change. I would say it would not change the prognosis of the patient as well. It is the alarm markers that really matter more, and we are obviously looking for one which we can identify superior to these. The day that comes, we'll be able to pick up the cases that can deteriorate relatively faster. We shall now be talking about treatment algorithm for management of a patient of SARS-CoV-2 infection. When would you categorize a patient as a mild case? Most of the cases can be managed with home isolation only. The features would be a fever with upper respiratory tract infection. There is no evidence of any respiratory distress. There is no shortness of breath. There is no hypoxia present in the patient. So it would be simply a symptomatic management. Though the older guidelines were that the patient should be admitted into a CC, that is COVID center, but you can very well notice the logistic nightmare that will occur for the government when they have to admit everybody with the COVID-19 into a COVID center. So the current guidelines are recommending that these patients can be managed at home also. Now, I have not written anything with respect to zinc or ivermectin, vitamin C, vitamin D, though lots have been said about it, because in the government protocol, nothing is mentioned. They've just mentioned symptomatic management. That could be as simple as paracetamol. And as I highlighted before you, that in the guidelines of Government of India, hydroxychloroquine was written, not that it is going to be highly effective in treating the case, but but it will cut down on the viral replication, so the infectivity of the patient to other people will dramatically reduce. In case the person deteriorates, so what are the parameters where patient will go out of a COVID center to a dedicated COVID hospital, or from home isolation will go to a dedicated COVID hospital? That is going to be when the respiratory rate will deteriorate. If the respiratory rate is more than 24 and the SpO2 of the patient is less than 94 on room air, that is when you are, that's the alarm bells that are ringing, and definitely the patient would need a hospitalization. Otherwise, home isolation or management at a COVID center is more than sufficient. As I said, if the patient is going into a moderate phase and is presented to you in the viral dominant phase, that is usually less than the 10th day, that is when remdesivir will definitely be highly useful. Though lots have been said about remdesivir, let me show you guidelines before I come back to this slide from Infectious Disease Society of America and also National Institute of Health. You can very well see, and this is what I was highlighting, that is what even people who are actively managing the cases have said, that it has definitely shown improved survival for especially patients who are severe. It does not work or is not effective for obviously mild cases. He said insufficient data to recommend for or against with respect to mild or moderate. So the current guidelines of Government of India are remdesivir to be given for both moderate as well as severe cases. And this is the data that is reiterated by National Institute of Health and IDSA, the Infectious Disease Society of America as well. So, how does remdesivir act? I mean, what is it going to do? You are very well aware of the fact that this is going to be acting like a chain terminator. I can use the word terminator here. That's how you can remember it. It's a terminator drug and a highly effective one. So this is going to inhibit viral RNA polymerase. And you can very well understand, as I casually said the word, for a non-medical person, I'll just say like this, that the virus will replicate. There would be a chain of viruses that would be formed. You obviously know that when I talk about the chain per se, I'm talking about the replication of the virus. So the chain terminator will definitely be effective. The second thing that has been talked about a lot, and there has been a lot of criticism with respect to convalescent plasma being given and not being effective, I can just say the fact that if you're using convalescent plasma in hyper-inflammatory phase, it will definitely not be effective. We have to use it with respect to a patient in the viral dominant phase, 200 ml, though I'll talk about dose also subsequently, and it can be repeated after 24 hours. Obviously, the donor should be having a high antibody titer. Then I would also like to mention casually, and please don't note down the next data that I'm saying, that is only for President Trump. You very well know that Trump was criticizing the management of COVID-19, and he was rather saying that people should not be using masks, and that is one of the reasons why the infection spread exponentially in America, and then President Trump himself suffered from infection. So the drugs that President was actually given to actually help him in a quick recovery was imdevimab, and that's just for mention here, though these are prohibitively expensive and are not available with respect to India. So the drugs to be remembered would be imdevimab and casirivimab, and I'm just putting a query here to say that not very sufficient data is available with respect to the effectiveness of these drugs. But yeah, President Trump, after getting them, said that I feel younger by a decade, and I mean, considering his personality, I mean, he can say anything. So I just want to say that yeah, a lot of drugs are on, I would say, the threshold of being identified as potential treatments, but at the moment we are talking about what are the government guidelines at the moment. And when it comes to a hyperinflammatory response, usually after day 10, that is when I'll be more comfortable giving steroids to the patient. Please remember, steroids are to be started both in moderate cases going into obviously a severe one. You can either use methylprednisolone or you can use dexamethasone. There is nothing like one is more effective than others. You know that every steroid would be having an equivalent dose, so obviously you can increase and decrease the dose depending on the equivalence per se. But most of the time what I have seen and what my colleagues have also said is that methylprednisolone, they have said, is having relatively a better response. Tocilizumab is again something which is I would say a plus minus response, so that is a investigational therapy as far as the government guidelines are concerned. And when it comes to a mild case, it is just symptomatic treatment that is required. But now we will talk about what is going to be done with respect to a moderate case. Criteria for moderate case, as I have requested you to remember, would be these values: 24 and 94, respiratory rate more than 24, SpO2 less than 94 at room air. That is when you are supposed to admit the patient in a dedicated COVID health center, and then specialized treatment of the patient will start. So let's look at what is going to be the specialized treatment for a moderate case, and that is where most of the MCQs that are going to be asked in your exam would basically focus on. One, he'll definitely love to ask you regarding what should be the target. Obviously, the SpO2 of the patient is deteriorating. What should be the target SpO2 of the patient? Earlier, I was saying the value less than 94, that's an indication for admission. He's saying that when you're targeting an SpO2, it's not that it's going to be suddenly increasing to 98%, because obviously the lung parenchyma is involved. So the target SpO2 of the patient is going to be something in the range of 92 to 96%. But if your person is having a comorbidity in the form of COPD, then the target SpO2 to be maintained, and this values to be remembered, is 88 to 92%. The patient in this case has been admitted into a dedicated COVID health center, that is a DCHC, as I showed you the slide note. So dedicated COVID health center, the short form is DCHC. And well, he can then ask you what is the preferred method of oxygen delivery. Now obviously you are having so many methods, right, from a venti mask to a non-rebreathing mask to a high flow nasal cannula. So you need to remember from the government guidelines, what he has said is that the preferred oxygen delivery, he has not said high flow nasal cannula. He has first mentioned regarding non-breathing face mask, and that is routinely available. I mean, you can definitely with a non-breathing face mask definitely achieve I would say a FiO2, which can be substantially important for maintaining the SpO2 of the patient. So most patients, what I have seen is that with the help of a non-rebreathing mask, the patient would be relatively more comfortable. Well, what is the disadvantage with respect to a high flow nasal cannula? It can definitely cause some aerosolization of the virus. So if the person is using a HFNC, then it is advisable that you also put a surgical mask on the patient's face, so that the aerosolization of the virus is lesser. And you very well know that how uncomfortable for the patient it can be. The message at the moment is two aspects. One is definition of a moderate case. I'll just repeat the fact once again, because that was one of the criteria of the MCQs in the exam, that when would you admit the patient. So it is not presence of comorbidity that matters in a moderate case. Comorbidity matters for a severe case. I repeat the fact once again, comorbidity like hypertension, diabetes mellitus, coronary artery disease, chronic lung disease, chronic kidney disease, chronic liver disease, all the standard comorbidities, they definitely matter with respect to admission of a severe case. But in a moderate case, all that matters is two parameters that you will see in the flowchart given in the Government of India guidelines, that is respiratory rate and SpO2, and then you need to remember the target SpO2 values as well. Another point that will always be useful for management of this patient is awake proning. Now, to explain the proning effect or the advantage of it, I would like to highlight that all of us in COVID-19 are using or washing our own utensils because there are no maids. So when you wash your utensils, you would be using a sponge, and this sponge will obviously soak water. But if you keep the sponge at one place, you will notice that all the water in the sponge will gravitate towards one side and the remaining part of the sponge will become dry. I repeat the fact once again, if you're using a sponge to clean the utensils, that sponge, if you keep at one area, you will notice that after some time, all the water will gravitate towards one side and the remaining part of the sponge will become dry. The same concept is what they're trying to do here, is that if you keep a patient in a particular position, like a prone position, then left lateral decubitus, then in right lateral decubitus, though this might look like oversimplification, but the point is, if you keep him in one particular position, then all the fluid in the lungs tends to gravitate towards one side and the remaining part of the lung becomes relatively dry, and it improves oxygen saturation. Surprisingly, this thing has worked. I know it will look very crude that I'm saying that fluid will gravitate to one side, so obviously the remaining lung will become dry, but this has definitely worked. So awake proning definitely matters, and the duration of this can be on the basis of comfort of a patient, that it could be ranging from anything between 30 to 120 minutes. That is, you can keep the patient in prone position for 2 hours, then it could be left lateral decubitus, right lateral decubitus, and then could be upright sitting, and this could be repeated, and this definitely helps in improving the oxygen saturation of the patient. Then he has recommended usage of low molecular weight heparin. The usual one that we're using is enoxaparin, that is a 40 milligram subcut shot once a day. So it is easy that you can be using it, once a day as compared to unfractionated heparin. And the reason for that is the hypercoagulable state that is setting in. When it comes to the usage of steroids, steroids are recommended both in moderate cases as well as in the severe cases. And most of the time you will notice methylprednisolone being used. It is not that dexamethasone is not effective, it's a cheaper alternative available. But I think that in the most of the guidelines, because methylprednisolone is given first, so if you have to select between the two, it's not that it is more effective, it is written first, so obviously it should be used. And then how long should steroids be used? That's a very common query that I'm getting from a lot of my physician friends friends also, and even from my juniors, because you see somebody is admitted for 14 days, would you be giving steroids? So the current guidelines are that there is no advantage of giving it for 14 days. Usually they're saying give it for 5 days. In some cases obviously you might extend it to 7, some cases maybe to 10, but the routine guidelines are give steroids for at least 5 days to suppress the lung inflammation that is occurring. Then in the government guidelines they have again mentioned hydroxychloroquine, though obviously the Solidarity trial and the NIH trial had discredited this, but because it is given a mention, then is the investigational therapies which are definitely be useful. So we'll definitely use remdesivir in this case. That would be dose is not important. You very well know that you have given it 200 milligram IV on the first day and then 100 milligram subsequently for the next 4 days. Total duration would be for 5 days. But when it comes to remdesivir, they can definitely ask you from pharmacology what are the contraindications. First and the foremost contraindication would be ALT AST ratios. If they are increased to more than 5 times of the upper reference limits, that's definitely a cause of concern. URN would mean upper reference limits. Yes, COVID-19 virus itself also causes damage to the liver. So in case you are having grossly elevated transaminases, you are definitely having a bit of trouble and dose adjustments might be required. If a person's estimated glomerular filtration rate is less than 30 ml per minute, that's definitely a contraindication according to the government guidelines. Then we are obviously not going to use it in a pregnancy setup. We are not going to use it in a lactating female, and we are not going to use it in children, especially less than 12 years of age. Another investigational therapy that can be used is CP, that is convalescent plasma. As I've highlighted, this is mainly going to be effective in the viral phase and would not be effective when it comes to a patient deteriorating into a hypercoagulable state. Then tocilizumab, the report is plus minus as highlighted relatively earlier. And what I can say at the moment is that you should be regularly monitoring the alarm markers. The frequency of monitoring the alarm markers can be 48 to 72 hours and can be changed on the basis of the requirement. The alarm markers are CRP, then would be D-dimer assay and ferritin. And if you have facilities, then you can obviously add interleukin 6 to the discussion as well. But at least the frequency of testing these can be at least 48 to 72 hours along with neutrophil lymphocyte ratio. And the higher it is, as I highlighted, that points towards the fact that patient can go and can deteriorate relatively faster. Now, how would you deliver oxygen to the patient is again something that has to be remembered. So as I highlighted before you, the first step that you would be using would be a non-breathing face mask. So I'm just using short forms at the moment because I've already written the data before you, and I would like you to note down the data for moderate and severe, especially from the exam perspective. So first step is NRBC, that is a non-rebreathing face mask. The flow rates can be as much as about 15 liters per minute. Then they gave a image-based question. So this is the second approach which we can be using, that is a high flow nasal cannula or a high flow nasal oxygen system that can be used. The flow rates in this case can definitely go up to 60 liters per minute. So the disadvantage can be aerosolization of the virus. So obviously I would say a surgical mask over the face of the patient will definitely reduce the load in such case. In case required and the patient is not maintaining oxygen saturation, he has obviously progressed into the severe case in which you will have to give a trial of non-invasive ventilation. Now, when I talk about non-invasive ventilation, I'm not talking about routine ventilators that people might be having at home for management of obstructive sleep apnea. I'm talking about a ventilator in a hospital setting where you are having a sophisticated circuit and you can adjust the PEEP as well. From this slide, they have just mentioned regarding what can be the approach that can be used in a resource limited setting, like you are at a smaller place where you may not be having all of the facilities. So he says that you can start with a nasal cannula at least initially, and then you can obviously upgrade to a non-rebreather mask. I want to highlight that in the government guidelines, your first answer will always be non-rebreather mask. That's the standard document which has highlighted this. And if there is no improvement in spite of this, you can definitely use high flow nasal cannula also. Though if you are not having these two, you can be using a plain nasal cannula and a venti mask. That is for resource limited settings. And you can upgrade subsequently to using a non-invasive ventilation. And the last step in severe cases would anyway be intubation. But you know how hard it is to manage patients who are already intubated with mortality rates going up to 40%. Our objective is usually to avoid the intubation process. So as far as possible, try to maintain the patient with on a CPAP or on a non-invasive ventilation. Now coming to the severe cases, I've already identified that if the respiratory rate is more than 30 and the SpO2 is less than 90% of room air, you definitely would be admitting the patient to a DCH, that is a dedicated COVID hospital. So it's a COVID center, it's a dedicated COVID health center, and then is a dedicated COVID hospital. Now in severe cases, what I also want you to remember remember is that this is where comorbidity will also decide hospitalization. What I'm saying is that if somebody is having a comorbidity and this value 30/90 is not being satisfied, even then I will admit the patient. Like suppose the respiratory rate is, let me say, 25 or 26, and the SpO2 of the patient at the moment is, let me say, 90, or let me say 91, 92. But if comorbidity is present, then patient will be admitted and treated as a severe case. The message is comorbidity matters not for moderate cases, but mainly matters for severe cases. Now, what are the important comorbidities that are to be remembered? So you very well know that obviously older age group, then would be hypertension patients who are at more risk, diabetes mellitus patients who are more risk, obesity, and then you can remember problems with the heart. So I can write cardiovascular disease, problem with the lungs, that is chronic lung disease. CLD traditionally is for chronic liver disease, so I'm writing it here. Then is going to be chronic kidney disease. So you can remember problem with the heart, problem with the lungs, problem with the liver, problem with the kidneys. They're all comorbidities. And even if these criteria are little off, exactly are not being satisfied, you would still admit the patient, and well, you would manage the patient in the following guidelines. So let's just look at what are the guidelines which are recommended for a severe case. So let's look at the interventions that would be done in a severe case. First step that you will answer in the MCQ will be a CPAP with a oronasal mask. Now suppose this is not given in the options, then you will answer NIV, that is a non-invasive ventilation with a helmet interface. The CPAP machine, as I was talking about, is not the one that is being useful for treatment of patients of obstructive sleep apnea. So I'm talking about the one in a hospital with a two-limbed circuit, and you can adjust the PEEP very definitely. And obviously high flow nasal cannula, because of the risk of aerosolization of the virus, is written at the bottom, though can be used. In case the patient is not maintaining oxygen saturation with these, you will anyway have to intubate the patient and manage him on the ARDS protocol, that is low lung volume ventilation. When I say lung protective strategies, I want to highlight two things here. One, you will have to keep the patient relatively dry. What I mean by dry is because that already there is a pulmonary edema component present. So if you will be giving too much of IV fluids for the patient, the pulmonary edema component can worsen. So we tend to keep relatively lesser amount of IV fluids to the patient. In lung protective strategy, the following steps are to be used. One is that the patient has to be kept prone. Now you very well know how difficult it is to keep an intubated patient in a prone position, because when you have to turn the position, there can definitely be a possibility of extubation as well. The indications for intubation and then proning is when the POO2 FiO2 ratio, you know the diagnostic criteria for ARDS is PO2 FiO2 ratio less than 300. If the PO2 FiO2 ratio is turning out to be less than 150, in spite of the FiO2 that you are giving, the fraction of inspired oxygen that you're giving to the patient is more than 0.6, and the PEEP that you are maintaining on the ventilator is more than 5 centimeters of water. In spite of these settings, if the PO2 FiO2 ratio is less than 150, then proning with obviously intubation is to be done. Then they'll ask you regarding what is the tidal volume that is to be set on the ventilator. So you know the normal tidal volume for routine cases like in Guillain-Barré syndrome or any other case where there's a diaphragmatic paralysis, the tidal volume setting is done at 12 ml per kg. But in this case, it would be done at 6 ml per kg. This is not per kilogram of whole body weight. It is mean body weight. There are formulas available by which you can calculate the mean body weight, not the total body weight. So it would be 6 ml per kg. The ventilation guidelines from MCQ would be that you should be keeping low tidal volume and a high PEEP in the patient. Along with this, obviously, effective neuromuscular blockage will facilitate the coordination of the breathing of the patient with the ventilator, because I don't want a asynchrony between the two, because that can cause a barotrauma and the lungs are already damaged. Along with this, low molecular weight heparin will definitely continue. We had already used heparin even in patients who are moderate cases. Steroids will definitely continue the same dosages. It's not that you are increasing the dose of steroids. The duration also remains the same in most cases, that is about 5 to 7 days. And at this point of time, if there's a concomitant sepsis in a patient, blood cultures are definitely being sold. So considering the sepsis protocol, antibiotics, consider it based on the culture sensitivity report, antibiotics can be started. When it comes to investigational therapy, I've already explained to you that remdesivir can be given, but not in the later stages after day 10. I mean, remdesivir will definitely not be working. CP is convalescent plasma, 200 ml single dose, repeated possible. I mean, you can definitely repeat it after 24 hours. And when it comes to the donor per se, the donor who has recovered from COVID-19 infection about 2 to 3 weeks back, the donor plasma immunoglobulin titer. I mean, though this is unlikely to be asked, but I just want to share with you that in the donor, the plasma immunoglobulin G titer should be at least more than 1:640. I mean, that means that you are able to actually, effectively neutralize the virus. Tocilizumab, again, because interleukin 6 can be elevated, and you also need to monitor the patient on with help of what is called as 6 score. This is again important from the exam perspective because they can ask you regarding sepsis induced coagulopathy. In fact, point number 8 that I'm mentioning before you is itself a separate question, that 6 score more than how much would indicate a bad prognosis with respect to COVID-19. Then it would be 6 score more than 4. Well, in sepsis induced coagulopathy score, what are the parameters which are to be kept? So there's an online calculator available. You just need to feed in the data and it will tell you the percentage of mortality. The data that you will feed in will be international normalized ratio, that is prothrombin time, the platelet count, then is the SOFA score. SOFA score means sequential organ failure assessment. In sequential organ failure assessment, we take into parameters with respect to the heart, that is like the blood pressure. You look at the parameters with respect to the lung. You look at parameters with respect to the liver, that is the enzyme values and the bilirubin values, especially bilirubin values, and the kidney values as well. So I have just highlighted in the SOFA score. I mean, SOFA is discussed separately even by the surgeon as well, and even I in MCQs have talked about the sequential organ failure assessment. There you look at the parameters with respect to the heart, the lungs, the liver, and the kidney, and then you will obviously feed in the report of COVID also of the patient, that whether he is confirmed by a rapid antigen test or RT-PCR, or whether he is negative case or whether is a suspect case, and you just have to click on, either the option will be confirmed case, COVID negative case, suspect case, and when you click on the submit button, it will give you the percentage of 28-day mortality. Like the report might say, there are 50% chances that this person will expire in the next 4 weeks. So 6 score basically helps you in identifying prognosis of your patient. And as I highlighted, I mean, our objective is two-pronged. One is to identify who will deteriorate. And second, we need to check out one who is deteriorating. What are the chances that we'll be able to save the patient or not? Because obviously I would like to utilize my maximum resources on that patient where the 6 score is less than 4, because the value, higher the value, I mean, the mortality rates are higher. So my resources are limited. So I would like to dedicate them to those where recovery is definitely possible. Apart from this, because we are talking about relatively older patients who are maybe possibly even on molecules like warfarin. So if you are giving antithrombotic therapy in a patient who is on drugs, then definitely like warfarin, the chances of bleeding can definitely be there. So there's also a score called as Hasbled score, which is to be taken into consideration when you are monitoring these patients, because in Hasbled score, there are a couple of parameters which are important from the exam perspective. So try to remember with me. Alphabet H would stand for hypertension. Alphabet A would stand for abnormal LFT and abnormal KFT report of the patient. Then alphabet S would stand for that patient already had suffered from stroke at any point of time. Alphabet B would talk about bleeding risk. Now, when I talk about bleeding risk in a patient, I mean that he could be, the patient could be like he has already had any kind of a bleed, or he is already on warfarin, which is causing a deranged prothrombin time or international normalized ratio. Then alphabet L would stand for labile international normalized ratio, that is fluctuating because of the coagulopathy component. Then E alphabet is silent, and D would stand for drugs. Drugs could be like with respect to alcohol, or I was talking about warfarin per se. A bit of overlapping information, but I want to tell you that like in atrial fibrillation, I have taught you about CHAD S2 VSE score, deciding on the need of anticoagulation. Whenever you are giving anticoagulation to any patient, there's a possibility of a CNS bleed as well. And in this case anyway, because you're using antithrombotic therapy, there's a possibility that the person might deteriorate. So Hasbled score and 6 score are used to monitor the course of the patients to evaluate the bleeding risk that could be developing in a patient. Please remember the fact that when it comes to severe cases, the dosage of steroids would remain the same, and in case the patient goes into ARDS, the major therapy that is to be done in the patient is low tidal volume with high PEEP. Now, there is another strategy which is available and is being used in some centers for management of cases where even you are not having improvement with the ARDS protocol. That is where you shall be using ECMO, that is extracorporeal membrane oxygenation. Well, what is the guideline for starting the patient on extracorporeal membrane oxygenation would be a PO2 FiO2 ratio less than 80. So let me just summarize. What I was saying was that when you admitted the patient, I'm just talking specifically with respect to oxygen delivery for the patient, you can initially be using a non-rebreathing mask in the patient. That's the initial strategy that you can be using. Subsequent to the non-rebreathing mask, another strategy that can be used is high flow nasal cannula. That's the initial step that can be useful for management for and maintaining oxygen saturation. But in case the patient is not able to maintain this, you will progress to non-invasive ventilation. Then you will intubate the patient and manage him with respect to ARDS protocol. And if you've done even this, ARDS protocol has definitely been deployed and still there is no improvement, we will be going in for ECMO, that is extracorporeal membrane oxygenation. So this is the step up that I'm talking about, that you can definitely upgrade your approach towards maintaining the oxygen saturation of the patient. So these are a couple of details which I wanted to remember for this particular discussion. Thank you so much for listening here. And obviously I would like to add a disclaimer that this is what the data stands as of today when I'm recording this lecture, and there's a high probability that the data might change in the next coming days or few weeks. So if there is a change, I'll definitely keep you updated and posted. Meanwhile, you just keep on revising the information that you have been taught in the routine app, and along with that, obviously continue doing multiple choice questions, and I'm very sure all of you would be coming out with bright colors. My best wishes.